Welcome back to Advancing the Management of Patients with Metastatic Melanoma, presented by Albert Einstein College of Medicine of Yeshiva University at OMED Live. You are tuned into today's final session, titled Targeted Therapy in Melanoma. My name is Dr. Patrick Hu, and I'm Professor and Chairman of the Melanoma Medical Oncology Department at MD Anderson Cancer Center. I'm pleased to serve as chair for this important educational program. Joining me today are Dr. Michael Davis, Associate Professor in the Department of Melanoma Medical Oncology at MD Anderson Cancer Center, and Dr. Kevin Kim, Medical Director of Melanoma Clinical Research at California Pacific Medical Center. Welcome, Michael and Kevin.
Thank you.
For those of you just joining us today, today's session is a live interactive program that allows us to have questions in real time throughout the presentation. I encourage you to send us your questions anytime by typing them in the box located in the lower left-hand side of your screen. I'll now hand the program over to you, Dr. Kim, to begin our presentation.
Thank you, Dr. Hu. This is the talk on targeted therapy in melanoma, and first part will be focusing on BRAF targeting therapies. Melanoma is a kind of common disease, and among them, BRAF mutations are the most frequent mutations known in cutaneous melanoma. Approximately 50% of melanomas contain BRAF mutations, whereas about 20% contains NRAS mutation. And among BRAF mutations, V600E mutations are the most common, accounting for nearly 70 to 80% of BRAF mutation. And less common is V600K mutation, accounting for 10 to 20%. And these BRAF mutations can activate and drive the MEP kinase pathways, which can activate and increase tumor cell growth, as well as the promoting metastasis and survival. And there are a number of selective BRAF inhibitors available at this time. And two good examples are vemurafenib and dabrafenib. And these two agents can effectively block MEP kinase pathway activations. As you see in this graph, that after 2 weeks of treatment with the vemurafenib, you could see significant decrease in phosphor-ERK the expressions, as well as the cyclin D and Ki67 expressions, which means that the target of MEP kinase pathway has been well inhibited. And in phase 3 clinical studies, the vemurafenib versus chemotherapy, then standard DTIC, was conducted. And in this phase 3 clinical studies, the overall survival as well as the progression-free survival were the co-primary objectives. And in fact, the vemurafenib had more favorable outcome compared to DTICs. So if looking at the median progression-free survival was 6.9 months of vemurafenib versus 1.6 months for DTIC. And also, median overall survival was 13.6 months of vemurafenib versus 9.7 months of DTIC. Overall response rate, 49% for vemurafenib and 6% for DTIC. So with this primary endpoint being met, FDA approved vemurafenib as a treatment for BRAF V600 mutations in 2011. Likewise, dabrafenib was also approved based on the phase 3 clinical study data. The primary objective of the phase 3 clinical study that compares dabrafenib versus DTIC was the progression-free survival. And hazard ratio was 0.37, the p-value less than 0.0001, favoring dabrafenib over DTIC. With the results, FDA approved dabrafenib as a treatment of, once again, BRAF V600 mutant melanoma in 2013. If you're looking at the clinical efficacy, overall response rate was 50% for dabrafenib and 6% for DTIC, and median PFS was 6.9 months versus 2.7 months of DTIC. And the differences are statistically significant. And if you wonder, dabrafenib versus vemurafenib, which one is better, which one is more effective agent, so far there's no head-to-head comparison of dabrafenib versus vemurafenib. But if you infer from two different phase 3 clinical studies, both agents have very similar overall response rate. nearly 50% response rate can be achieved with either medication, and median PFS was almost identical at 6.9 months. So choosing between these two can be based on the toxicity of this agent. Looking at the common adverse events of the selective BRAF inhibitors, dabrafenib has little more hyperkeratosis and pyrexia versus vemurafenib, but vemurafenib has little more of the proliferative skin disease such as squamous cell carcinoma of the skin and keratoconthoma, also little increased risk of the fatigue, arthralgia, and skin photosensitivity. And something to remember about BRAF inhibitors are that it's only effective if a tumor contains V600 BRAF mutations. And if you're looking at wild-type BRAF, there's no response rate in early phase 1 clinical studies. So it's very important you only select patients with the BRAF mutations to offer this agent. And also, development of cutaneous squamous cell carcinoma and keratoconthoma can be done through paradoxical activation of the MAP kinase pathway in normal keratinocytes. So as you can see in the slide, left lower corner, we see the BRAF mutant cells. When BRAF mutation is present, as we talked before, it can activate the MAP kinase pathways. With the presence of BRAF inhibitor, we can effectively block the activation of the MAP kinase pathway. But in normal cells, such as in skin cells in the same patient, which does not contain BRAF mutation, wild-type BRAF proteins may not do much to the pathways. In fact, it can play a role in senescence of the cells. When BRAF inhibitors is present, then it makes conformation change so that BRAF proteins can make complex with the RAS and CRAF proteins. In fact, this complex can drive the MAP kinase pathways. So same medication in the same patient can do exactly opposite effect on MAP kinase pathway based on the BRAF mutation status.
So what you're saying is in patients with this BRAF mutation, you have to make sure that those patients have the BRAF mutation before giving the BRAF inhibitor.
Absolutely.
Otherwise, you could cause growth.
Absolutely.
Of the tumor, right?
If patient has possibly some other mutations, such as NRAS mutations or KRAS mutations, it's also possible that it can actually drive cells to grow faster.
One of the other distinctions is that although most frequently the mutations we detect in BRAF affect the V600 site, which is what vemurafenib and dabrafenib were designed to inhibit, as we see more broad molecular testing, we're actually discovering many other mutations in the BRAF gene. But to date, those other mutations have not been shown to predict sensitivity to these BRAF inhibitors. And so again, specifically, we use these BRAF inhibitors in patients who had the BRAF V600 mutation.
Thanks.
And as we talked earlier, the median PFS is about 6 to 7 months. That means half of the patient will have disease progression after only 6 to 7 months. And if you're looking at different patients, there are different variety of the patterns of disease progression. In some patients, tumor progress all over the place, and some patients only isolated 1 or 2 places, which can be easily resected, and it can continue treatment. So in some patients, continuation of BRAF inhibitor can be a valid way of treatment, while other patients, the continuation of BRAF inhibitors can be questionable whether this can be beneficial or not. If you're looking at molecular level or tumor tissue levels, there you can see after 2 weeks of the BRAF inhibitors, we can see significant decrease in phospho-ERK expressions, meaning that target has been met and MAP kinase pathway is inhibited. But at the time of disease progression, and some of the tumors can reactivate the same MAP kinase pathway. And many of the patients with this melanoma, when this resistance happens, the reactivation of MAP kinase pathway is the real problems. And these reactivations can be achieved through a number of the mechanisms, such as acquire of a new NRAS mutation, acquire of the new MEK mutation, as well as the alternate splicing of BRAF, which can cause change in the binding of the vemurafenib or dabrafenib to the BRAF.